Dr. Sakatu, take it away.
It's really wonderful to be here. We're so grateful and wow, so many people showing up. And that's just proof that we stand together and we're here to support each other and uplift each other. And my name is Leslie Ann Sakitku. I'm a rheumatologist with a special interest in cardiopulmonary diseases related to autoimmunity, and that includes myositis. I'm here with my vice chair, of which Julie Peck is also another one, Dr. Pedro Machado. And so, Pedro.
Thank you, Leslie. And it is a huge pleasure to be here today. And I will start by introducing MIHRA. So MIHRA is a charitable non-profit research organization, and we try to bring together investigators from all disciplines, patient advocates, and partner organizations to support a vision. And that vision is to create a world where you can cure myositis together. We aim to achieve this by accelerating highly collaborative holistic research worldwide, and we serve as a platform where research organizations, patient advocacy groups, the pharmaceutical industry and regulatory agencies, they can converge to tackle complex challenges such as those that we've been witnessing in myositis, namely designing and implementing innovative clinical trials, strengthening professional education and training, building robust and sustainable research sites, and cultivating the next generation of myositis researchers and clinicians. Now, through these efforts, we are all working towards improving global care for individuals living with myositis diseases. We also offer some valuable online services, including a global directory of myositis specialty clinics. We also have an up-to-date listing of current myositis studies and clinical trials to help both patients and healthcare providers find relevant studies for their patients. And our goal is to invigorate professional education, enhance clinical trials, and fortify myositis research sites, all with the ultimate aim of advancing care and finding a cure for myositis. So next slide, please. There are approximately 7,000 rare diseases worldwide. In the United States, a disease is classified as rare if it affects fewer than 200,000 people, or about 1 in 1,650 individuals. Now, in the EU, a disease is considered rare if it affects fewer than 1 in 20,000 people. This means that in total, there are over 30 million people in the US living with a rare disease, and over 36 million people in the European Union that are affected by a rare disease. This is approximately 1 in 10 Americans that will develop a rare disease in their lifetime. So rare is really not so rare. And importantly, rare diseases contribute significantly to chronic illness, to disability, and to premature death. And they affect both children and adults. In addition to the physical impact of the disease itself, living with a rare disease can severely affect psychological and social well-being. Unfortunately, many patients with rare diseases are often marginalized. Early detection and awareness is critical in managing these conditions and preventing the long-term damage and disability. In this context, myositis is an umbrella term for several rare diseases that affect the muscles and can also impact other organs or systems, including the skin, the lungs, the heart, and the gastrointestinal tract. Next slide, please. So living with a rare disease can often make individuals feel alone, outnumbered, or even less deserving of attention and care. However, an inspiring and surprising fact is that rare disease research contributes significantly to the greater public good. Many discoveries in rare disease research have often led to major breakthroughs in understanding and treating more common diseases. Rare diseases often provide valuable models and patterns that help clinicians improve their approach to diagnosing, understanding, and treating common disease. So rare is more than just a number. So when we look at the approximately 7,000 rare diseases together, we see that rare is in fact a superpower, a powerful force for innovation, discovery, and improving care for all of us. Now, in the field of myositis diseases, countless researchers are working tirelessly toward finding cures, improving treatments, and developing strategies that allow patients to live more comfortably and enjoy life. However, research in this area does face several key challenges. The low incidence and prevalence of the disease makes large-scale studies difficult. The identification, recruitment, and retention of subjects is often challenging as the patient population is small and often geographically dispersed. Disease progression can be slow, making it harder to assess over time. Phenotypic changes can be difficult to measure and to track. Sometimes there's limited natural history data to guide research. Standards of care keep evolving or are not even fully established. And endpoint design and validation for regulatory trials can present a challenge. There's also a relatively lack of viable therapeutic candidates. However, things have changed significantly, I think, over the last few years, and organizations like TMA have had an important impact in these changes. There's an increase in the number of potential therapeutic targets developed through basic and mechanistic studies. Preclinical discovery and development tools are becoming more sophisticated with advancements in both in vitro and animal models, high-throughput screening facilities, and more robust standardized operating procedures for therapy testing. I think diagnostic capacity is improving worldwide, aiding in better identification and stratification of patients. I think the infrastructure supporting proof of concept trials is also evolving. Genetic research is improving and uncovering disease-causing mutations in genetic rare disease, but also genetic modifiers that can be important in acquired diseases. So I think we are witnessing change and the emergence of new partnerships among advocacy groups, academics, corporations, governmental agencies, and patients are accelerating this progress. So, Leslie, maybe I'll hand it over to you now.
Hey, thank you. That was wonderful, Pedro Machado. So in rare diseases, we stand strong, and we have to stand strong, just like we're gathering here today. And we're really showing who we are, and we're here for each other. And courage is coming from Latin, courage in French. You know, it comes from the word heart, and it means big-heartedness. And we need this big-heartedness to face the challenges of living with a rare disease. Part of that is whether we're investigators or whether we're patients. In order to do a good job, we have to look after ourselves. We have to move our bodies for our health. We have to invest time to look after our nutrition and get good sleep and make good choices. Connecting with, oh, I see, I'm a little bit off here. So, and we need to remember also that we may have a disease, we may be an investigator, but we are people first before we are a health condition. And we ask that of each other and recognize that we are people first. And so in order to stay strong, connecting with others is crucial, like we're doing today. We're coming here together, we're standing with each other. But part of that is selecting those who bring us joy. That's part of self-care. Gaining disease knowledge. And it's very important that when we're gaining disease knowledge, we're doing that together as investigators, as patients, and sharing that knowledge. And if we are a patient, if we are an investigator or a clinician, understanding the strategies and skills related to self-advocacy in and out of the treatment room, those are things that can bring us closer to health and bring us closer to each other. One of the things that I've found in my life is that the more that I participate, the more that I learn, the more that I'm engaged with others. And I begin to feel stronger because I'm supported by this wonderful network of colleagues, both investigators and patient colleagues. So, and in terms of research, we shine our magic. We shine our magic through our hearts, relating to each other's hearts as human beings, and bringing to this difficult situation ingenuity, creativity, listening spirit, so that we can problem solve together through this current of sensibility to each other and to the question at heart. And we learn together. And we are out there raising awareness about myositis and rare diseases in general. And this is our magic. And we share with each other 360 perspective of what it is to be working within a rare disease as an investigator and to be living with a rare disease as a human being. And it's only with these insights that we can help each other along. We don't know about natural history unless we truly know about natural history, unless we ask patients what from their lens, this blow-by-blow experience of what it is to live and live with the symptoms, how the symptoms evolved, to really understand the pace of the disease and the pace of the symptoms, and to really truly understand the burden, which also helps us to prioritize our research. And part of our magic is really remembering that the heart of everything that we do is not just brains, but it's brains about bringing humanity to everything that we do, and not just saving the world, but saving our one-on-one relationships, and remembering that without everything else, if we don't stand together and we don't work hard to preserve our relationships, we lose our greatest asset. And we'll remember that we are all humans and we are all navigating through this life as human beings. And so we all come with our triggers and our misconceptions, but we learn and we forgive each other, and we're always expressing gratitude to make it work. And when we step off and out of line, because we're humans, we are with gratitude, and we apologize and we move on. And very important in our worlds of nonprofit work and science is that we recognize that not everything is truly urgent. Some things are urgent, yes, but not even those very urgent things in the scope of what we do, like getting a grant in on time. It's not the end of the world. And knowing those things that are of lesser urgency, so we can invite collegial compassion and compassion for ourselves, because that's the essence of being able to continue this work. And the other thing that we do and need to continue to do as terms of rare disease magic is to work to preserve our best resources. And what is that? First of all, that's patient time, and that's patient life years waiting for a cure. And that means avoiding delays in research through developing pathways that avoid delays and use funds efficiently, and do not keep patients hoping to get into a clinical trial in limbo while they're waiting for waiting to enter a rare disease trial. So that means expediting institutional delays and having a special fast track for initiation of rare disease research. And as patients and actually as investigators, we're sending out lots of qualitative surveys and expert perspective surveys. So the more that both of us, patients and investigators, can participate in all types of research, the further along we are going to get. And then ensuring that the community voice is driving the research, that the patient priorities are driving the research that's selected as priorities, and also that we as a community are guiding research as opposed to, well, dare I say it, the almighty dollar. Okay. So two quick examples that I'd like to share with you. And I'm just going to send out a couple of PDFs now and also a link to our patient contact registry. Hopefully everybody will get those now. But one of our posters that we were going to present at the NIH FDA Rare Disease Conference was our work with the carbon hand study. And what was marvelous about this study is that it took a year from design to implementation to analysis in this rare disease. And we were able to have sufficient recruitment for very good power. The carbon hand is a glove that is worn on the hand in people with neurologic deficits of hand function. And this is very important consideration in people with myositis, but especially in IBM, where it is a hallmark of the disease that hand impairment is progressive. And what this glove does is it senses the through the neurologic tone what the wearer would like to do. And what it does is it provides supportive force so that that task could be completed, whether it's grabbing or pincing. So what we did is we joined forces. This is how we got this study that would have probably taken 5 years to do in 1 year. Joined forces. We convened an investigator global team of physical therapists, occupational therapists, patients, of course, MDs. We designed the program. We circumvented institutional delays. And how did we do that? Well, we used a single site IRB as the NIH supports. And within 2 weeks, rather than the customary 8 months, we were ready to go in terms of all of our approvals. We worked with industry, and industry was on board supporting us with training and providing us devices. And we then collaborated with our gorgeous patient organizations. So with the help of the TMA, Rachel Bromley, Linda Colbert, we were able to get this trial fully recruited over the weekend of the TMA conference. And this was a positive trial that demonstrated a clear benefit for patients with IBM in feasibility and usability. The other study that demonstrates that we were going to share at the conference that demonstrates the community voice coming together and rare disease magic was the CAR T studies. And everybody has heard about CAR T studies by now, I'm sure. It's very exciting. It's a very aggressive form of treatment, but it's a very important resort. We were finding that as a patient community, as an investigator community, that we were feeling a little bit inundated by the number of these types of trials. They were outnumbering our other types of myositis trials. Patients were feeling a bit pressured with ads and not feeling they were getting enough information. And the same with the investigators, not sure what we're getting into. So under qualitative research expertise, we decided to go to the community, ask the community, get guidance from the community, find out what's going on. We did so through eliciting open narrative on surveys, analyzing this data, holding a live forum, presenting what we learned, drilling deeper into these potential issues. And what we found was patients and investigators shared many of the same concerns. Like I mentioned, too fast, many patients being recruited at once without really understanding the safety implications, need better information, materials. That was very clear. And we were also concerned that patients that might be enrolled may have actually benefited from trying safer, effective options. And how do we control for that? And also, ultimately, there was no agreed upon treatment algorithm to define what exactly treatment failure was, which actually will impact patients from getting the appropriate care and this being used as a last resort, but also impacts the data coming in, that we're really defining, having well-defined inclusion criteria. So again, the end of this provided several deliverables that we are working on currently, which includes patient-centered, patient-driven communication protocols and educational materials, developing treatment algorithms to define what is truly treatment failure, engaging in dialogues between regulatory agencies and industry, patient, investigator communities, and also supporting our investigators so their time is not wrapped up in the logistics of setting these complex trials up, but rather caring for our patients.
Thank you, Leslie, so much.
Yes.
This is Paula, TMA's Executive Director, and that was a terrific overview. And I think you and Dr. Machado shared so much about what we can take pride in for rare disease. And, I think it's not widely known that many of the advancements that have benefited all of human health have originated in rare disease. So this was really fascinating. I would like to invite Dr. Goyle to briefly react and to reflect on the question we've received about how the NIH sort of pauses and disruptions may impact myositis research now and going forward. So let's pass the mic to Dr. Goyle and then back to you, Leslie.
Well, thank you, Dr. Machado and Dr. Saketku. I couldn't agree with you more about your comments and your thoughts. For those of you who don't know me, my name's Namita Goyle. I'm a neurologist, I'm a myositis specialist, and I've had the amazing honor of being chair of the Medical Advisory Board at TMA. I've actually been a part of the TMA community for the past 10 years. And I'm so grateful to be here today. I'm a physician scientist and I work daily to try to improve the lives of patients with myositis. It's really because of this increased awareness that's really led to a surge in research and therapeutic development. And this has happened, like Dr. Machado and Dr. Saketku has said, because of efforts of collaboration from a network of clinicians, scientists, pharmaceutical companies, the NIH, but most importantly, from all of you, the patient community. I'm really honored to be a part of this community that works so tirelessly and fiercely to improve the lives of patients and with myositis. So to answer Paula's question, I look at this NIH interruption as a pause, but I have seen from even just this program today that it is not stopping any of us on the myositis side. The researchers, the scientists, the clinicians, we are still continuing our work. We don't anticipate stopping any of our work. Our passion remains, and irrespective of what the NIH is planning on doing, which none of us know, we are continuing our work. And thus far, the message has been to continue our work. And so I don't really foresee it being a major hurdle or barrier for our care in myositis. And I think this program really attests to the devotion and commitment that us myositis experts, community all have. I think this meeting is going to be a wonderful testament to the commitment that we all have in myositis research.
Thank you so much, Namita. Dr. Machado, would you like to make any additional comments or reactions?
Well, being a person living in the UK, you know, I see the news in the US with great concern, let's say, but I also have a lot of confidence, trust in my colleagues in the US and various organizations that I'll know will be able to overcome the difficulties, and they will be resilient, and the rare disease research will win. And we, on the other side of the pond, we're supporting you all, and we can count on us, you know, to partner with you in the even if the times to come might be difficult.
Thank you so much, Pedro. That's so well said, especially the part, if you don't mind that I repeat you, where you said rare disease research will win. I feel that very deeply, and I know all of you do too, and I really feel the support as well. And thank you so much on behalf of our community. While we would have very much enjoyed the privilege of interacting with our medical advisors and these esteemed scientists at their posters at the Rare Disease Day program at NIH and FDA that was postponed, this is truly the next best thing. So Leslie, back over to you to lead us through several flash science talks. And this is going to be a little bit fast and furious, as the saying goes. So consider this a sampler of science, if you will. Leslie, flashing back to you.
Welcome to this exciting journey that we're about to be on together. And we're going to begin with a patient-driven discoveries and priorities, preferences, and attract to research from the MIHRA Heavy Lifters, Ingrid de Groot, Leah Kolsters, Marie-Christine Breveld, Karen Norris, Karen Chung, Helian Alexanderson will be popping in. The MIHRA Heavy Lifters, and the question is, does over-reliance on manual muscle testing in myositis commonly negate patient voice? And does this cause treatment delays leading to long-term disability? This is the question.
Thank you, Leslie. Hello, everyone. My name is Ingrid de Groot. I live in the Netherlands and I'm a medical advisory board member of TMA. And I will talk you through this fascinating short presentation. The Heavy Lifters, as you see here, is a small group of women living with different types of myositis, who have been sharing experiences regarding diagnosis and treatment. And we found out that we have a lot in common, in the sense that we all used to be very active or even athletic women who know their bodies very well, and who, as a consequence, knew for sure that something was wrong long before any doctor could or would confirm this. So idiopathic myopathies, as we have heard, are rare diseases of muscle injury, which can also affect lung and skin, heart, and the GI system. And the muscle severity varies, and a widely used and heavily relied upon instrument by clinicians to measure this is the MMT-8, where the MMT stands for manual muscle testing, and Helene will talk us through it later. But however, active disease or flares can be undetectable by using the MMT-8, because what we found out by talking was that as athletic patients, we all performed well or above average for women our age in this MMT-8 test. And we also learned that this was often the reason for withholding or postponing treatment at the time, despite the fact that we some of us reported progressive muscle weakness or even provided doctors with objective records of deteriorating performance. Also, concurrently active skin disease did sometimes not lead to muscle treatment. As such, over-reliance on MMT8, leading to possible treatment delay and potentially to long-term disability as a result of that, is a key concern for people living with myositis. So we will now give short introduction. This is me. I was diagnosed with dermatomyositis in 2007, and the first signs that something was wrong were skin symptoms on the eyelids and on the hands and the fingers, plus the fact that I could not keep up any longer with the men in my sports group, and those were men I had been working out with for years. And despite increasing muscle weakness in shoulder and pelvic area, this decreasing muscle endurance and prolonged recovery time, my high score on this MMT8 test was one of the main reasons to delay muscle treatment, which started only 2 years later. And by that time, also my neck muscles and breathing muscles were affected. And despite this treatment, I never regained my former performer levels. Next, please.
Hi, I'm Karen Norris, and I am a 3-time Paralympic swimmer. I have 3 world records and 7 medals to my name. And in retirement, I still trained seriously. A few years ago, I experienced a 15% drop in my performance in just a matter of 2 months, which was extremely alarming and unexpected. So the next 2 years, I spent visiting countless doctors, and I'd show them my rash and my itch, and I'd talk about my cough and countless other symptoms in addition to my performance drop. They'd do the manual muscle test, and they'd say, "Oh, you're strong." And I'd say, "But you don't know how strong I was a little while ago." But they would dismiss that, and they'd say, "Maybe you're just depressed." And so it took 2 years to get diagnosed and start treatment. It was extremely frustrating, and well, let's change that. Next.
Thank you, Karen. Leah, I think the slides are just a little bit delayed, but it's up on my side.
Thank you, Leslie. Hi, I'm Leah Golsos. I'm 13 years ago, I was diagnosed RA, and after 2 years and 44 pounds less, I got the anti-synthetase syndrome. For my profession, I was working in construction, being a tile layer, and often I lifted 38,000 pounds a day. So that's about 2,550 stone. After taking immune suppression for long enough for it to work, tapering down became the main fight. Though creatine kinase wasn't high enough to take immediate action, I became weaker. The MMT8 test became the standard check. Though this said nothing about the strength to perform and only that moment for one attempt. So, in their opinion, I was scoring above average for a female my age. So this left me taking prednisolone for 6 years before I gained remission eventually with Rituxan. 6 years of muscle loss and gaining loads of myositis related diagnoses like GERD, oesophagus paralysis, costochondritis, and several more. Could this all have been prevented? Maybe not all, but at least a few, or at least half of my
Hi
lost
everyone, I'm
muscles.
Karen Ching. I was originally diagnosed with polymyositis in Singapore in 2006, and I now live in Switzerland. And last year, about 20 years later, we found the SRP antibody, and I'm officially classified as IMNM, immune-mediated necrotizing myopathy. I do believe that my early diagnostic and treatment path, because I was stereotyped as a very young patient and a very active patient, that perhaps the more aggressive treatments were not offered to me early enough, which resulted in me spending about 1.5 years in a wheelchair. And it wasn't until I couldn't swallow anymore before I got IVIG. I do think as well that a heavy reliance by the clinicians on just clinician-reported outcomes may not always concur with what the patient is feeling. And in terms of our fatigue and endurance issues as patients living with myositis, this often does not show up so well on the MMT-8 score. Next.
Hello, everyone. My name is Marie-Christine Breveld. I was trained as an occupational therapist and later became a manager of health centers. I'm a sporty lady. In the top right photo, you can see me sailing at the World Championships in the Bahamas. When I started to lose strength, I still sailed races and was very muscular. I did my own research and was afraid to have IBM. In the past, I treated patients with ALS, but this syndrome was different. My neurologist saw a muscular woman and did not believe me. My request for a muscle biopsy was not honored. In the manual muscle test, I was very much stronger than her. She asked me to do a deep squat. She did not accept that I indicated I could not do a deep squat and forced me to do it anyway. I fell flat on my back. Finally, I was diagnosed with ALS in late 2018. Even in the second opinion, I was diagnosed with ALS. A year later, after a muscle biopsy, I was given the correct diagnosis of IBM. To all doctors, patients may hold some valuable information. Thank you.
So based on our common experiences, we discussed and arrived at 4 major strategic areas that we should be working on. We considered the existing evidence regarding patient-relevant measures. So we took some actions to understand wider patient experiences, and we have today, even in the PDF that Leslie has just shared in the chat, we are trying to provide already some immediate patient-relevant guidance for clinicians. And also we are considering how the patient community can support research efforts in this area. Next slide. From the light literature review that we've scoped, we've noticed that reliability issues do exist relating to the MMT-8 testing. There were also some literature regarding the FI3, the functional index 3, which Helene will talk a little bit more after this slide, which appeared to be more sensitive, had more granular measures, and were better in terms of objectivity than the MMT-8. Muscle impairment may not necessarily mean active disease. However, also active muscle disease may be suggested by a shorter disease duration, progressive impairment or gradually slow progressing disease, flares, and also active disease in other organs such as the skin and the lungs. There is currently no standard assessment yet for skin with myositis-related disease activity, and also there is no currently acceptable scale which exists for patient experiences of skin and muscle. Helene, over to you.
Hello, everyone. I'm very excited and glad to be on this meeting together with all of you on this important day. I'm a physical therapist specializing in myositis, living in Stockholm. So I'm going to discuss some performance differences between the manual muscle test and functional index 3. Next. So the manual muscle test 8 muscle groups, MMT, measures isometric muscle strength, the force that you can produce over 3 seconds. And it includes 8 muscle groups, and the score ranges from 0, which means almost no muscle activity, to 10, which is considered as a good muscle strength. Next. There is, however, some complexity of subjective bias and application of technique. So for the MMT grades, 6 to 10, where the patient is rather strong, so the assessor puts on extra resistance to try where that the patient is supposed to uphold. But here it is dependent on the stature and the strength of the assessor, not only the patient. Next. So the functional index 3 measures muscle endurance rather than isometric muscle function. And as we heard, the Myositis Heavy Lifters, and as I hear in my clinic from many people with myositis, is that muscle endurance seems to be more relevant than the isometric muscle strength. The FI3 is also more sensitive to detect muscle impairment and muscle changes. It measures 3 muscle groups, and it is the patient performed independently. The assessor is only observing, counting number of repetitions that the patient can perform, and is not involved in putting on extra resistance or so. These are the 3 muscle groups: shoulder flexion, head lift, and hip flexion. And with this slide, I want to show you, I don't know, can you see my pointer? No.
Yes, we see it, Helly.
Okay, so on this axis, we have the manual muscle test, 0 to 100%. And on this axis is the FI3, FI2, from 0 to 100%. And as you can see, the majority of cases, 1 dot is 1 patient, are performing very well on the MMT. There's not much room for improvement. This individual performs 100% on MMT, but on the same time cannot perform any of the repetitive measures in the functional index 2. So most patients here seem to struggle to cope with the endurance tests. So I think this means that it's not, the MMT8 is not sufficient to capture a muscle impairment in myositis. Thank you.
Thank you, Eline. Okay, so regarding the second major strategic area, we discussed possible ways to investigate wider patient experience. And we plan to do this through open-ended surveys to obtain experiences, and later on also surveys to quantify these experiences and stories, which we'll then share with the patient and investigator communities. And to provide immediate patient-relevant guidance for clinicians, our discoveries prompted us to compile 2 preliminary guides to integrate patient-reported experiences and to prevent treatment delay. First, a patient-relevant diagnostic guide with points to consider the likelihood of active disease. And secondly, a guide to navigate the shared decision-making process between patients and clinicians. And Karen will now take you quickly through these 2 guides.
Thanks, Ingrid. So these are some points of guidance for clinicians to be alerted to active disease, even when measures such as the MMT8 scores reflect otherwise. We hope that this will help to avoid any treatment delay, which could result in muscle damage and long-term progression of myositis. Many of these are interplays of symptoms versus signs and may affect some of the treatment selection that a patient receives. While we don't have time to go through each of these, there will be a PDF available. I think Leslie has already shared that, as well as we will share further information on the MIHRA website.
The PDF is in the chat.
We also identified some critical areas for two-way conversation between patients, the care partners, as well as the physicians, on whether these treatment decisions can be made when active disease status is unclear. Although these discussions do take time in the clinic, it can make a big difference in the patient outcomes. Again, we will not go through each and every one of these points, but please refer to the PDF. And MIHRA's website will also have this information, or just feel free to reach out to any of us after this meeting.
Thank you, Karen. So when looking at the fourth major strategic area, which is how the patient community can support all these efforts, we aim to increase patient involvement in improving clinical assessment in myositis. And this could be done by several ways. One is by involving patients in all phases of a study, from study design to implementation and dissemination. And patients and their advocacy organizations can help by participating in focus groups, in surveys, or by providing feedback to researchers and investigators, for instance, in the development of apps or measurement instruments. And finally, and importantly, patients can help by joining the MIHRA Patient Contact Registry, which you can do through the QR code you see here on the right, or through the link on the MIHRA website. I thank you all for being here today, tonight with us. And on behalf of all people living with myositis and their loved ones, I want to express my sincere gratitude to MIHRA for their decided commitment, their dedicated commitment to holistic science, and for the acknowledgement of the patient voice herein. Thank you very much.
Thank you, everyone from the Heavy Lifters. That was really super and amazing. I'm so grateful for this time, your voice, and your work on this. Is Vicky Worth in the audience, and is she here? Ready?
Yes, I am here.
How fantastico, Vicky!
Okay. So we're going to talk about unintended consequences of clinical trials in rare diseases. I think we've already heard about some of the issues around muscle exam, and I'm going to be focusing more on the skin exam. So next slide. And I do some work to try to advance studies. And so this is just letting you know some of the work that I've done. Next slide. And so we already know about myositis, so I can really be very brief about that. And we've talked about the TIS as more of a muscle measure, which includes the MMT8. And so the TIS is being used as a primary outcome for most studies. What that means is there's no direct measure of skin activity. And we'll talk about the implications of that. Next slide. So it basically, because the TIS is more of a muscle measure than anything, it means that the trials are mainly recruiting patients who have muscle disease. And we know there are many, many patients who have only skin disease. And what that means is that the trials are being done with skin patients not included. And when drugs get approved that help the skin, it's pretty hard to get it for the patients who don't have muscle disease. And so that's sort of the capsule summary of what I'm going to tell you. But there's a lack of skin assessment, and we can go to the next slide. And basically what we know is from a patient voice that the skin is really important to people. So what this was actually was a survey or poll that was done during a patient-focused drug development that was involved TMA and as well. And what you can see here is that the skin complaints were like the highest number of complaints that patients had. And below that was fatigue, and even below that was muscle weakness. So you can see the problem of only having a muscle-focused measure is you're leaving out a big complaint that people seem to have. Next slide. And so we do actually have a skin measure that's been validated and used in many of the trials as a secondary outcome. But because it's only secondary, it means that we can't, when the approvals happen for the muscle patients, it doesn't necessarily extend to the skin. Yeah, keep going. So the CDASI, can you go back? CDASI in combination with measures of muscle weakness and overall DM disease activity may better capture improvement. And so we've developed a new measure, next slide, that allows us to combine elements of the TIS, namely the MMT that you can see up there, and maybe someday we'll be swapping out the MMT for the FI3 that we were just hearing about. And then the CDASI you can see is the skin measure, and they're given equal measure here. What we're showing you with the improvement score is identical weight to muscle and skin. And then there are global assessments from the physician side and the patient side. And all of these together can give us a composite tool that will allow measuring our patients. Next slide. And so we applied that to a study that we did, a phase 3 trial. And what this is showing you is that when you use the TIS, which includes the MMT, that when a patient wasn't better on the skin response side, the left side, they weren't better with DMOMs. But when you could show that the patients were better in terms of the skin with TIS, they were even better with DMOMs, and that's not surprising because there is a direct measure of skin. So the orange line is doing better than the blue line, but we can, in this kind of situation, include patients who are skin-only patients with significant dermatomyositis, with itching, and really a problem. On the right-hand side are the muscle responders. And what you're seeing here are the people who didn't respond to this particular med. The TIS and the DMOMs didn't show very much. It's a flat line at the bottom there. But when you look at the muscle responders, again, you can see that the DMOMs captured the muscle responders better than TIS. And that's, again, I think, a reflection of the fact that often the skin and muscle get better together. But again, more sensitive measure. Next slide. So compared to the TIS, DMOMs is simpler. It's 4 instead of 6 components. It captures greater improvement in both muscle and skin, and it seems to perform well as an outcome measure in dermato trials that include patients with both muscle and skin activity. Next slide. So what is the impact of, again, not having a skin involvement? Well, 20% of dermato patients have no detectable muscle involvement, and they're not in trials. 40% of classic DM patients with muscle disease, and we've heard a lot about the muscle disease, but in a lot of patients, it does get better. And then you're left sometimes with chronic sort of skin issues. And those patients also, because they're not weak, cannot be included in trials. So we're excluding a lot of patients. And we know that the skin is important to our patients. Next slide. So failure to include these patients means that it can be hard to access. And I'll give you an example. So we use IVIG for dermatomyositis, whether it involves muscle, skin, or both. So we've been using it for many, many years, and we were lucky to get really a very unique approval from the FDA for use of IVIG in a trial, which was great that the trial was done, but the only patients in the trial were muscle patients. They had to be weak to get into the trial. What that meant is when we got that approval, some of the skin patients started having trouble getting IVIG. And I now spend time doing peer-to-peer complaints with the insurance industry to try to get IVIG approved. So it's really important to include our skin patients. And so keep going. We want to have the ability to include all our patients. And if we can do that, it will prevent loss of access to meds for patients whose active disease manifestations fall outside of trial inclusion criteria. Including more patients in trials of novel therapeutics will be very helpful because there are such limited treatment options, and we all really hate the use of steroids. Protecting recruitment is really important because we won't be having studies if we can't fill the studies that we have that are very exciting with really great drugs. So we need to be able to broaden out who can be in trials for a rare disease. And I think that that's the bottom line is we are really all of us together working to validate DMOMs in more of a clinical trial setting so that we will be able to enroll many different types of patients. Thank you very much. And this is to acknowledge all the people that have contributed.
Dr. Worth, thank you so much. Our next speaker is Dr. Helene Alexanderson.
Thank you, Dr. Sakit-Ku. I'm going to speak a little bit about why exercise is a vital part excuse me, in the treatment of myositis. And as we have been talking earlier about, it's important to distinguish between active inflammation and damage. So in remission, when there is no active inflammation anymore, exercise is actually the only effective treatment to improve physical health as well as psychological well-being. Next. And with this slide, I want to show how the view on exercise in myositis have changed dramatically over the last 30 years. In the 1990s, when I started to study myositis, all textbooks said it's harmful, you shouldn't exercise, you should rest, especially if you have a recent onset or disease or flaring. But since then, more than 40 publications support safety and efficacy of exercise in people with myositis. And today we're actually back. And today we're actually investigating safety and effects of high-intensity interval training in recent onset myositis. So exercise is a cornerstone in the treatment of myositis. Next. So physical activity is any everyday activity producing increasing energy expenditure above resting sitting levels. And next slide will show health enhancing physical activity recommendations. Exercise is a planned physical activity with a goal to improve physical fitness. And we can establish an exercise dose by using the fit factors, frequency, intensity, time. And that means the number of weeks or months that you have to continue to start to see an effect and what type of training we are doing. Now, Leslie. Thank you. So these are recommendations from the World Health Organization, which is based on very strong recommendations from literature. And we should all strive to achieve these recommendations for physical activity. And we know that people with myositis often have, from the beginning, an increased risk of cardiovascular disease, type 2 diabetes, cancer, fatigue and pain, and so on. But striving towards these recommendations can give you a lot of very important health benefits that you can see listed on the left. So we should try to be physically active at least 150 minutes on a moderate level. And that means you get your heart rate up, but you are still able to talk. Or do at least 75 minutes of very vigorous intensity activity, which means that you have a very high heart rate, you're not able to talk to anyone. And in combination with this, we need to do strength training twice a week. It's important to minimize the sedentary time. So just standing up from the computer, getting a cup of coffee before you sit down again, that actually has health benefits. And for people with myositis, and as well as for people over 65, it's important to train your balance to reduce the risk of falling. And this might seem as very challenging to reach these goals. I think we all might be struggling, but you can start where you are and if you just increase a little bit, that will give you health benefits. And it can be a long-term plan on how to be more physically active. Next. There are studies showing reduced depression and disease activity. So this study looked at 24 weeks of functional strength training in non-IBM myositis. And as you can see to the left, the black line is the exercise group, and they had significantly reduced depression compared to the non-exercising control group. And they also had markedly reduced disease activity in the exercise group compared to the control group. Next. This is a home exercise program that we have developed. So you do these exercises 5 days a week and can combine them with a 20-minute walk. And this program has been extensively evaluated as to safety for people with recent onset active or flaring myositis. And it can improve muscle endurance and quality of life. And importantly, we could see some reduction in bodily pain. And when comparing this program to a randomized, to a non-exercising control group, it showed that those who started training already at time of diagnosis, they had a much higher level of physical activity after 1 and 2 years. And they were also improved in muscle endurance and aerobic capacity in the long-term follow-up compared to the non-exercising control group. Next. This is a program that you can do when your disease is less active, when you don't have so much inflammation. It's training twice a week, mainly biking. You can start on a lower level, but slowly work yourself up to the goal intensity. And next. And here we could see an significant and clinically relevant improvement in aerobic capacity in the exercise group compared to the control group that were a little bit worse after 12 weeks. We also looked at lactate levels. So lactate is a byproduct of energy production when your muscles work hard with little oxygen, and it can make your muscle feel fatigued. So we could see a significant reduction of lactate levels and a more than doubled biking time to exertion compared to before training, and also compared to the control group where you couldn't see any difference. Next. This program also reduced disease activity and fatigue. It increased the number of small blood vessels in the muscle. Genes related to muscle growth and blood vessel growth was upregulated. And this together show that exercise not only improve whole body aerobic capacity, but also muscle aerobic capacity. And genes related to inflammation were downregulated. Next. This is a home exercise program that was developed and evaluated specifically for people with IBM. And it's a 16-week program where the goal frequency is to do it twice a day for 16 weeks. You can start on moderate intensity only once a day and slowly move up to goal frequency. It's important to have frequent telephone follow-up and measure function and strength in between to make sure that this training program is well tolerated. It showed that muscle strength improved also in muscles that are most affected, such as the quadriceps, the thigh muscles, and finger flexors. Patients improved in their ability to stand and walk. And here are some slides that show results from our recent exercise study that we did at Karolinska University Hospital. And we looked at safety and effects of high-intensity interval training in myositis. Next. So the HIT program comprised of 3 sessions per week. The goal intensity was to do 6 30 seconds all-out intervals where you reached at least 85% of the maximal heart rate. And then you have 2 minutes with active rest in between. And then they did strength training. And the control group performed the home exercise program that we have been using. I showed it a couple of earlier slides that we have been using for many years. And next. We could see that this is the exercise group, and they improved 16% in aerobic capacity. So the dotted lines is 1 patient, and this is the mean value. And 16% is a very large improvement. A 10% improvement is clinically relevant. And that was this statistically significant improvement compared to the control group, who only had a 2% change. We could also see that the HIT improved in muscle endurance and self-reported physical function and general health compared to the home exercise program. In both groups, there were some signs of reduced disease activity. In the HIT, reduced the pulmonary disease activity. And there were responders according to the new total improvement score. Overall, there were otherwise no changes in CK levels or pain or fatigue. Next. So in summary, exercise have positive effect on physical capacity, disease activity and inflammation, muscle health, fatigue, and psychological well-being. Exercise should be individually adapted to physical fitness, pain, and fatigue. And this just hit the button many times. These are all the organ systems, or many of the organ systems in your body that are positively affected of exercise. So exercise is medicine. Thank you.
Helen, thank you very much. Now, Dr. Eli Nadav.
Thank you, Dr. Sakatu. So in these 5 minutes, I am just going to touch base on how our strength lies in unity from a different perspective. Because the disadvantage of just saying that if we put our numbers together, we're not that rare, it's still buying into the concept that numbers matter. While in fact, every patient deserves to have the most accurate diagnosis, the best outcomes, best treatment regimen, which is the foundation of precision medicine or individualized medicine. And the best part of research to help further illustrate that concept is translational research or translational sciences, which I will share some examples with you in these 5 minutes. Next, please. So to demonstrate that, we would have to consider novel concepts. One of which is there's a difference how we approach a research topic if our aim is diagnosis versus therapeutic approach. Because if we want to diagnose someone with a disease, we want to highlight the most specific findings that occur only in this disease, the most specific biopsy finding for that particular patient or disease. However, from treatment perspective, it doesn't work like that. Different diseases can share different mechanisms, and findings or breakthrough treatments in one disease could be borrowed to other disciplines and other domains and other diseases. Hence, the rarity really does not matter. And that's what translational science is, bringing basic science or benchwork closer to clinical application, and also application of these findings across multiple disciplines, and hence strength is unity regardless of the numbers. The other concept is how we're approaching these diseases that I will illustrate in a research project that was published. Next, please. So there is no better way to illustrate that concept than IBM and the relationship between IBM, aging, and mitochondria. As now mitochondria and mitochondria therapeutics is a hot topic in aging, and all aging-related diseases share a lot of common mechanisms that we're hoping any breakthrough treatment in one area could be borrowed and translated to other diseases if we can find that same pathway, same mechanism also happens in that disease. Next, please. And IBM, although classified under idiopathic inflammatory myopathy, it is a disease of aging by definition, and it affects males more commonly than females. It does not respond to immunotherapy. And almost every single IBM biopsy patient has evidence for mitochondrial dysfunction, and mitochondria are the mothers of aging. Same with the other form of myositis. There are also shared pathways through the mitochondria. Next, please. And what made that field very interesting, because the old concept of the mitochondria are the powerhouse of the cell is very outdated. The mitochondria role is not just to produce energy. And it's not just a black or white, is there mitochondrial dysfunction or not? The mitochondria are very rich and complicated organelles. Yes, they produce energy, but they regulate metabolism, they regulate our immune system response, and also they decide the cell fate and when the cell has to die to just limit the damage. Because of that, they are now considered a signaling organelle. And every disease will have mitochondrial involvement. But the question is what type, what mitochondrial behaviors and functions are affected in each disease, And any treatment for any of these behavior, any of these functions could be translated across disciplines. Next, please. So to give you an example, this first project was already published where we focused on one of the mitochondrial function, which is called mitophagy and the inflammasome activation. Why it makes sense? Because IBM, one of the most prominent features of IBM is inflammation and mitochondrial abnormality. And we know that the mitochondria play a major role in regulating inflammation. And this is the link to the paper that's already published. But to summarize it in just 1 minute, under normal condition, when our body is subjected to any form of stress, whether it's relating to aging, to the environment, or others, the mitochondria leak some of their content, and that content is known to trigger inflammation. Specifically, one type of inflammation that you'll be hearing about is called the inflammasomes. The inflammasomes are now implicated in many diseases of aging, Alzheimer, Parkinson, loss of muscle with age, sarcopenia, and aging itself. Hence, the finding in one disease, regardless of its rarity, could have major impacts on other fields as well. But under normal condition, in individuals with intact mitophagy, mitophagy is the ability of the cell to eliminate damaged mitochondria and take them out of the cells, then the cell will get rid of these damaged mitochondria, will get rid of the inflammasome, and the cell normal function is restored. In IBM, we have mitochondrial damage, leakage of mitochondrial content, triggers inflammation. But now the cell cannot get rid of these mitochondria because the mitophagy is impaired. Then we have more oxidative stress, more mitochondrial dysfunction, more inflammasome activation, and so on and so forth. This creates what's called a vicious cycle, or a vicious cycle that's self-sustained and causes a lot of cell damage. And that's a new concept of all the diseases of aging. We probably may not find what caused the disease. It's not just a cause or effect. But from day one in those diseases, there are some vicious cycles that are happening, and we need to know how to break them, how to intervene on them, regardless which came first, the mitochondrial dysfunction or the inflammation. It does not matter because this cycle is really damaging the cell. Most importantly, there are very major sex differences, and males with IBM have way worse mitophagy, probably, than females. That could also explain some features of the disease. Next. And in the slide, I'm just summarizing the second project. It's published, it's posted on bioRxiv and currently under review, where we defined the metabolomic map in muscle of patients with IBM centered on the mitochondria. And we show different metabolomic shifts that are shared with other diseases of aging, with diseases of muscles, with sarcopenia, and so on and so forth. And the only part of this project that I'm showing you here is when you correlate these changing in metabolism, changing in genes with clinical findings, you see what correlates with what, to just have some idea of what's clinically important. And then when you look at that table here, the strongest correlation of these changes is with sex. That tells us there are a lot of genes and metabolites that drive disease differently between males and females. And also a lot of these correlate with the loss of strength, meaning they are of clinical significance. We don't know yet what's causing the disease, what's a reaction to disease. We're just still describing what's going on. And with that, we would open up all these findings that are shared with other diseases. For instance, there are now treatments for mitophagy in Parkinson's disease already in clinical trial. If we further demonstrate what type of mitophagy defect are happening in IBM, could we borrow that treatment and try it in IBM? And that's the beauty of translational sciences and the importance of funding translational research. Next, please. So for the most part, translational research is funded by the NIH. And of course, foundation play a role in that as well. Not much with the pharmaceutical company. And therefore, the current changes with the NIH and the uncertainty of the NIH could markedly impact translational research and could even bring it to a stop. Also knowing the US is a leader worldwide in translational research. If we want new treatments, new targets, new diagnostic biomarker, that all happens under translational sciences. I personally had minimal impact on me, nothing compared to other people, but as a follow-up study to this, I had submitted an R01 application that was supposed to be reviewed 2 days ago, but unfortunately that meeting is now canceled without any instructions on if that will happen and when will it happen. Hopefully that's short-lived. And again, this translational research, translational science is another example how our strength is in our unity and how numbers do not matter in the field of research and improving the quality of life of patients with myositis. Thank you.
Thank you, Ellie, Dr. Nadav. So grateful for that wonderful talk. And now, because we're mitochondriacs at MIHRA, we are going to talk about now more mitochondria with our esteemed colleague, Dr. Christian Lud. Thank you, Christian.
Thank you, Leslie. Yeah, I'll continue on the same topic as previous speaker here and discuss how our power plants, the mitochondria, may be on the go in myositis. Next one, please. So as noted in prior talk, mitochondria, we usually think about them as these power sources, and they're inside of cells producing a lot of energy, which is important for our cells, not least our muscle cells. But however, it's worthwhile noting that we don't think that mitochondria are human. We think they come from bacteria originally. They coexist with us. And as such, they also contain many things that look like bacteria. And since they look like bacteria, our immune system is very intrigued by these mitochondria. However, the crux here is that unless we think about the inflammasome that Dr. Nadav mentioned, our immune system will not see mitochondria if they are still within cells. But if they are seen by the immune system, they can evoke autoimmunity. We see a lot of autoantibodies towards mitochondria in different myopathies. And we know that these mitochondria can promote inflammation. But would it be that a mitochondria would be seen outside of a cell? Are they on the go or do they stay inside of cells? Next, please, Leslie. So we have reason to believe, both in myopathies and also in other inflammatory diseases, that mitochondria do not stay within cells, but they actually move. They move around. And we can see this in inclusion body myositis, where we see in the fibers that they are COX negative, meaning they lack mitochondria. Where are the mitochondria going? We see in JDM in the lower left page, using electron microscopy, that muscle tissue are pumping out, throwing out mitochondria into the extracellular tissue, depositing them for our immune system to see them. And we have published a paper describing on why and how that is happening. But also in our peripheral blood, our immune cells, like neutrophils or platelets, they can also, when activated, release these power plants that are now inflammatory, looking like a bacteria in your blood. And one of those important molecules that they release, we refer to as FMET here in red circles. So this is, of course, all theoretical. Do we then have evidence that this is occurring in patients, and what are the implications of that happening? So next slide. So we have measured these mitochondrial peptides in the blood from a ton of different patients and different disorders, and we do find in both juvenile dermatomyositis, adult dermatomyositis, and inclusion body myositis that patients have elevated levels of these mitochondrial markers in blood. So it's something we can measure in the lab. And this seemed to reflect very well muscle function. Though we may not agree that MMT8 is a good marker or not, this is a soluble marker you can measure in blood that even in IBM seems to correspond to muscle function. And this would be one of the first, if not only, good soluble marker that we have for IBM to study disease activity or muscle function. So thinking now about us having all of these mitochondrial markers, mitochondrial components, if you would, in blood, the question is, do these contribute now to peripheral systemic inflammation in these patients? So next slide, please. So this is going to be a little bit messy, but I'll try to lead you through it just to give you an overview of what we're trying to accomplish with this project. We do try to bring novel biomarkers to the market to try to help investigators and clinicians to monitor better disease activity and so forth. But when it comes to long term, we try to identify new mechanisms of how inflammation and damage occur in patients, trying to develop new targets to treat. And we do know that these mitochondrial peptides, FMET, activate immune cells through a receptor called FPR1. There's a drug we can use called cyclosporin H, which blocks this specific pathway. Oh, sorry, Leslie. And what you see to the right is that we have found that serum or blood, if you would, from patients with inclusion body myositis and dermatomyositis are inflammatory. They evoke an immune response. But if we add in that system cyclosporin H, so this mitochondrial peptide inhibitor, to that system, we normalize it. We remove all of that inflammation from the peripheral blood. So we do believe that blocking this pathway, which we have shown in other diseases as well, could be helpful and a new target to consider in myopathies. So thank you, Leslie. Next, the final one. And this is just to summarize and saying that we believe that mitochondria are not only inside of cells, but they are on the go in myopathies. And we can use these mitochondrial markers in blood and tissue to help monitor disease activity, assess prognosis, and guide treatment. And we believe that targeting these mitochondria and making sure that they stay where they're supposed to do may alleviate inflammation in myopathies. And then finally, on the last slide, I would like to just acknowledge all of my team members and collaborators for all these projects, funding, and not least MIHRA and TMA for all of their support on this. Thank you.